Okay, good afternoon, everyone. I think we'll make a start, and welcome to the Oak Room here at County Buildings in Staffordshire and the Staffordshire Health and Wellbeing Board this afternoon. Before we start, there are some new faces, some faces I don't recognise, so we'll just quickly go around the room, introducing ourselves and who we're here to represent. So if we start on my right, please, Jenny.
Jennifer Norman, Member in Democratic Services.
Thank you, Chair. Liam Archer, Democracy and Governance Officer.
John Topham, working in public health, bit of health and care.
Miriam Hussain, Public Health Team.
Harrison Masters, Public Health.
Mia Manahan, Public Health.
Claire McIver, Assistant Director, Public Health and Prevention at the County Council.
Richard Harling, Director of Health and Care for the County Council.
Gary Jones, Chief Exec, Support Staffordshire.
Phil Pusey, Chief Exec, Staffordshire Council Voluntary Youth Services.
Dave Bassett, Engagement Officer at Healthwatch.
Yeah, Baz Tamis, Manager at Healthwatch Staffordshire.
Councillor Charlotte Atkins representing Staffordshire Moorlands.
Hi, Lynn Miller. I'm the Portfolio Director for Improving Population Health in the ICB.
Hello, Nikki Harkness. I'm here from the ICB as well. I'm representing Elizabeth Disney, who's the Chief Transformation Officer for the ICB.
Nikki Bromwich, Associate Director for Mental Health, Learning Disabilities and Autism and Children and Young People. I'm here to present the item alongside Natasha.
Afternoon everyone, Natasha Moody, Assistant Director for Wellbeing Partnerships, and again here for the first item.
Good afternoon, Councillor Jeremy Pert. I'm the Cabinet Member for Health and Care at the County Council.
And I'm Mark Sutton. I'm Cabinet Member for Children and Young People and the current Chair of the Health and Wellbeing Board. And if I could go back to Bernie.
Thank you, Chair. Apologies, colleagues, for my slightly late arrival. Bernie Brown, Director of Children's Services.
Lovely, thank you very much, everyone. So if we move on to the agenda proper then. Item 1, apologies.
Thank you, Chair. We've received apologies from Dr Rachel Gallio, Elizabeth Disney, Jill Heasom, Rita Hesseltine, Emily Clark and Ian Reid.
That's lovely, thank you. And do we have any declarations of interest from any members present? No, I'll take that as a no, thank you. And then the next item is the minutes of the previous meeting. Can I take those as read, unless anyone's got any? No, okay. And any matters arising from those that anybody wants to raise? Okay, thank you. And do we have any questions from the public?
No questions received.
Okay, thank you very much. In that case then, we'll move on to item 2 proper of the agenda, which is Health in Early Life Priority Progress Update. So Natasha and Nicola, over to yourselves.
Thank you, Councillor Sutton, and afternoon everybody. So Nicola and I are going to try and canter through a bit of an update really in terms of health and early life. We will try and split the slides between us, so bear with us as we go, if that's okay. So this is the second update on this priority area. For those of you that weren't aware, Nicola and I are the senior officers related to this area that lead some of the programmes of work that sit underneath this. So we've just provided a bit of a presentation as well as the report in the pack to just give an overview of how we've made progress towards the priority around health and early life. For those of you, again, that weren't aware and weren't here last time, the 3 areas particularly are focused under this priority area around infant mortality, breastfeeding and smoking in pregnancy, although the report does cover a broader range of things that are going on in that area that do relate to those areas. I'll pass over to Nicola for the infant mortality.
So since the last time we were here at the Health and Wellbeing Board, it was recognised that obviously infant mortality is really a cross-cutting theme across a number of different areas, and that it really required a sort of system-wide approach to try and bring that together into one single stream that had that level of accountability. So there was a group established with very good membership from across all parties, as we know it's such a cross-cutting theme. So that was done in September 2023. It has, as I said, the overall accountability and leadership, and reports into the ICS CYP programme board in terms of updates. Due to a change in sort of leadership at various different points, we've actually took a stock take of that group and actually re-established it very recently in July 2024. So there's a new chair for the group, which is Cynthia Florane, who's a public health consultant from Stoke City Council, and that's co-chaired by Matthew and also Alexandra Jakeman. So it's really sort of starting to reinvigorate what we're doing around that agenda. So, as I said, it's a very good representation. We have managed to achieve sort of full compliance with the Saving Babies live bundle, and all referrals are made within 24 hours in terms of care flow. We have obviously made improvements around perinatal mental health, and that's just an update there in terms of an e-referral form. But importantly, we have released significant investment again this year into perinatal mental health services, so around about £700,000 additional funding, and that is really to support obviously the care of women, but also the assessments and care of their partners, as well as extending those families onto caseload for a longer period of time, and extending the amount of psychological intervention and variety of psychological intervention we can to support those mothers. In terms of our next steps for perinatal, for infant mortality, an action plan is in development. So that's very much going to focus around maternal weight, so preconception, during pregnancy, and postnatally between pregnancy. It's also looking at fetal alcohol syndrome disorder around that preconception work as well. And that really has to have joint ownership with our maternity colleagues, and that's we're in the process of identifying that. Another area of focus is around tobacco dependency, and again making the stronger links in terms of perinatal mental health. So at the moment we're in the process of developing that action plan with a review, an update process into our activity for 24-25 and beyond. So we should be able to bring a much fuller update back around this agenda for the next meeting.
Okay, then just picking up on Child Death Overview Panel. So some of you will be aware that we have to have a Child Death Overview Panel. So part of our arrangements in terms of developing the infant mortality piece is very much linked to the work that the Child Death Overview Panel do. So we've got a really good group in Staffordshire who meet and have oversight of all of the child deaths. They look at all of the modifiable factors when a child does die. We have an annual report that's published every year. I'm not actually aware when the last Child Death Overview Panel report came to this group, and I do think one of the recommendations that drops out of this overview is for you to receive the report from that group. There are some deaths that occur in Staffordshire where actually there isn't necessarily a link to that infant mortality work, but there are some where it would be helpful, I think, to have that awareness of that work that's happening as part of the Child Death Overview Panel, and also understand the role and relationship between the infant mortality work. So we've just kind of given you some headlines there in terms of the data. Last time we came to talk to you, there was a particular conversation that focused very much on the rate of infant mortality and how we were seeing that change. We talked a lot about the data and how there was that lag in the data, but we can confirm that our kind of early predictions around that reducing have transpired. So there's been less child deaths that have occurred in Staffordshire and Stoke-on-Trent over the last 12 months, which is positive, and I think a credit to all of the work that people are doing in that space. We also have seen a number of modifiable factors that have been identified, but you'll see later on in the presentation that some of those modifiable factors that were previously identified are no longer present when we look at some of those child deaths, again, I think, which is a credit to some of the work that the team have been doing around this particular area. Another area we wanted to give you an overview of is around smoking and pregnancy. So most of you will be aware that there is a correlation between mothers who smoke during pregnancy and the outcomes of those babies. We have seen some really positive work taking place, and I think this kind of goes to Nicola's point around maternity services. We've been doing an awful lot of work with maternity services, and we are absolutely incredibly pleased really with the work we've done to make sure that there is that good connection between maternity services and the smoking and pregnancy service. This time last year we weren't necessarily identifying the right kind of people, and we weren't necessarily seeing that all of those parents were taking part in that smoking and pregnancy intervention. We actually widened the intervention to include smoking mums and dads, and we have seen that that is starting to have an impact. We have got a new service that's in place, and actually the smoking at time of delivery has reduced, which is really, again, positive. I'm not saying that that's kind of down to all of the work that's happened in the last 12 months. I think it's taken a lot longer to kind of achieve some of those results. But we have seen significant improvements in Cannock, North Staffs and East Staffs, which again are where we're seeing those referrals again going into those services. So I do think there is a correlation. What we have seen though through the CDOT process, so through that child death overview process, is we've identified that actually smoking is still contributing to those modifiable factors. So we're not resting on our laurels. We know that there's still work there for us to do in terms of making sure that we correctly identify and make sure that that support is in place for those parents who are working their way through that process. We have, like I said, strengthened that relationship, and actually we've seen really good take-up with the CO2 monitoring in place through antenatal appointment. And as you can see there, I mean, it's an amazing achievement. This time last year, we were nowhere near in that space of 100% of those appropriate referrals now being picked up by the smoking and pregnancy service. We were seeing a lot of kind of referrals coming in, and then they weren't necessarily following through to appropriate action and intervention, which I think is a credit to the work that we've done with maternity services really, and their help and support in identifying those mums who would benefit from that support. One of the other modifiable factors is around safer sleep. So we've just given you an overview really in terms of some of the work that has been identified. I think it's fair to say that this was probably the #1 priority for the Child Death Overview panel. They've done an awful lot of work on safer sleep. This was previously one of the top rated modifiable factors when it came to child deaths. They've done an awful lot of work in trying to make sure that that help and support is in place to make sure that that isn't necessarily an area that we identify. We've done a lot of work with Midlands Partnership Foundation Trust and the Health Visiting Service there. We've been tracking through the safe sleep advice that's given during mandated contexts through health visiting. And actually we are seeing some positive results as a result of that, those conversations that they're having, leading to changes in kind of safe and sleep arrangements in family households. The Child Death Overview panel have also worked to develop a Protect Your Baby Bundle leaflet, which has gone out to partners and professionals and also parents themselves to make sure that they're aware of what they can do to help develop safer sleep habits. And we've also facilitated a number of events and training. And actually that's where I said that modifiable factor hasn't been identified this year, whereas it would have previously been the top rated one. So I think that does go to demonstrate that actually, you know, those modifiable factors, those messages are getting out to the workforce and they understand the importance of cascading those. Another area is around breastfeeding. So we know that breastfeeding rates across Staffordshire are low. They do remain below the national average. And that is a cause for concern. Actually, we've got an infant feeding leadership group that's been in place since 2021. There's been a number of partners that have been working together to try and make sure that they've got that plan in place to coordinate their efforts and make sure that there is that whole system approach to breastfeeding and encouraging people to breastfeed as a first option. I have to say there's a lot of work that's required as part of that, which is about getting the community and the culture right in terms of encouraging people to breastfeed. That infant feeding group is just in the process of updating their plan and continue to identify and work along a number of key issues, including tongue tie. And again, we continue to monitor that work very closely. I think it's fair to say that we think we've got some issues in terms of data recording as well when it comes to breastfeeding. So we are doing a lot of work to try and drill that down as part of that plan to make sure that we've got an accurate picture of what's happening in Staffordshire at the moment. I think I'm passing over to you, Nicola.
So in terms of Better Health Staffordshire, obviously there's a strategic approach around tackling the causes of excess weight in terms of that healthy environment. So there's a number of emerging themes in terms of that system-wide preconception working as well. And again, a lot of this is linked into the infant mortality steering group. So there's work really around action plans and campaigns to support this programme, and the strategic partnership group is also sitting on that sort of emerging workshop as well. Healthy weights in particular, so this has been identified as a system-wide priority in terms of the CYP programme board, and we're looking at developing a strategy, and that's really focusing on the whole spectrum of population health to specialist support. So an ICS working group has been sort of developed, and an action plan with key leads from all of our partners across the group. A SWOT analysis and stock take of existing service provision and community assets, supporting healthy weight in children and young people has been completed, and Matthew's heavily involved in that, and we're looking at the findings to inform that good practice across the ICS, as well as also identify any gaps that might need to be addressed. A needs assessment and evidence review are currently underway to understand what is the evidence-based good practice for healthy weights in children and young people, with a particular lens around health inequalities and how that might impact our children and young people in terms of equity and access to services. So there are some emerging priorities that have been identified that we need to look at. So obviously developing a whole system approach to healthy weight. Just move on, Natasha. Thank you. Improving the equity of provision in communities and that overall provision. So very much developing children, young people and family support services. Strengthening the links across the healthy weight pathway, really linking into those healthy lifestyle support and that early identification, increasing capacity within local services, particularly around where tertiary support for excess weight might be required, and also developing that MDT approach around their families. In terms of next steps, what we're looking at is that completion of the rapid needs assessment and that evidence review. There's an intention to develop an engagement plan around collating evidence and how we use that within the existing stakeholder forums and services to maximise that impact. Again, using that to inform further strategic priorities, and also being really clear about the delegation of ownership of that action plan to relevant partner organisations, because this priority sits obviously across the whole membership of the ICS, and it's trying to be really clear about who actually needs to sort of own some of those actions moving forward.
Okay, so the last couple of slides then are more about kind of the emerging picture and some work that's kind of happening more globally and not necessarily related to the health and wellbeing strategy, but are absolutely interdependent and possibly causes a need to reflect on the prevention strategy that we do have in place. So nationally, there's been development of family hubs. Staffordshire is committed to doing that as a local authority. We've been working very closely with a number of partners to develop our family hub model. We've done a soft launch of the 13 family hubs over the summer period. And for those of you that don't know, the family hubs are really supposed to be essentially a place and a way of working, but it's really a kind of approach that the partnership takes to make sure that families have easy and integrated access to the support that they need. And it really challenges us as a system to change the way in which families might experience our services and support. So rather than kind of coming to somebody who's a professional within that system, it would be more about how we work with them to develop and determine what support and help they might need, using their voice and experience to kind of guide some of that work. We've included an update there on the 6 areas which we've identified and agreed as a partnership are the areas where we want to do greater work. They're all areas that are aligned to the national framework in terms of easy access, making sure the voice of the family are heard, that we've got good leadership and governance in place, that the data and the outcomes that we deliver against are clear and that we're all working towards a common framework, that we've got that community offer of support, and also that we've got a workforce that's skilled and equipped to help families to deal with that. I think the reason for mentioning that is twofold, really. So I think the first part is that actually families have told us, both nationally and locally, that sometimes it's really difficult to find help and support. They can sometimes feel like they're being passed round the system rather than actually accessing timely help and support. And so I think there's an ask really of help from this group to make sure that actually that family hubs and that prevention agenda are built into our psyche and are part of our way of working. And also for you to think about more broadly how you and your organisations might play into that ask. I have to say there's been some really great examples of how partners have kind of worked with us to develop that model, and also how they might support the rollout of that. But actually it's going to take a lot of people with a lot of time and a lot of energy and resource, but it also will require us, I think, reconfiguring the way in which we work so that it's less around subject-specific areas and more around that kind of broader prevention and how we align and integrate some of our services and support. So again, I've added it in here for context, but also to ask the group for some support around that agenda and landing it within your respective organisations. As part of that, and again linked directly to this priority, is an ask of us to develop a first 1,001 days pathway. In Staffordshire, we didn't really like the idea of talking to parents about the first 1,001 days pathway. It doesn't sound that great, so we've called it the Bumps to Toddlers pathway. That's been developed collaboratively, working with parents, working with partners, and is now up and running. So we've included a link to that in the pack. So again, encourage you all to have a look at that Bump to Toddlers pathway. That's really the first iteration of it. I have no doubt in my mind that that will be reiterated as we go on. Parents have already been talking to us about how they'd like to put their own videos on there about what people never told them about becoming a parent. So I'm sure that that will be something that kind of grows as we kind of get underneath it. Again, quite simply, that pathway outlines the help and support that is available to families, and again, should be something that we're keeping up to date and reiterating as new services and support comes on board. So again, please do encourage your teams and people that you're working with to familiarise themselves with it, but also to keep people up to date if they think it needs to be reiterated and redeveloped as it goes. So today in the report, the board are asked to note the following recommendations, and I shall pass back to you, Mark.
Okay, thank you very much, both. It was most interesting and informative. Happy, obviously, to take any questions. Charlotte.
I just wondered what assessment you'd made of poor housing conditions on the impact of health in early life. Housing wasn't mentioned during your presentation.
Interestingly enough, as part of the CYP programme board, a couple of meetings ago, John Rouse, City Director for Stoke-on-Trent, had actually asked that very point. So he'd asked the group to do some focused work looking at housing and the impact of housing. The output of that work hasn't been back to the group yet, but it is definitely something that's on the radar. And again, more than happy to feed back here once that work has been concluded.
I mean, we have had, quite a push on things like damp and mould, and I was quite surprised that that's not really, you talk about smoking, but you don't talk about damp and mould. And certainly where I am in the Moorlands, we have very leaky houses, and I would have thought that would have some impact both on maternal health and on infant health.
In terms of modifiable factors, it's not something that's been identified or come up as a concurrent theme. But again, I think that is why it's important that this group has a look at that Child Death Overview Panel report. And again, asks those kind of questions, because it's not to say that it's not something that the group should be focused on, but it's not been identified as part of that process.
Thanks, Chair. Just a couple of points. I just wondered if you could comment on how, particularly related to family hubs, whether you could comment on how the co-production promise that was agreed across the system last year is being used to underpin the development of the quality framework there, and also how the transition from children's centres 0 to 5s as opposed to family hubs 0 to 19s is going, and how you envisage that playing out over the development phase.
It's been really interesting, I think, in terms of the learning from the co-production promise. I think there is there was possibly an underestimation of how that might impact in terms of the way in which we work with one another. For example, I think in Staffordshire County Council, you know, I can talk very honestly about the fact that our comms teams, we had to have some really difficult conversations about what it might mean in terms of we didn't have all the answers. We were working with parents and children themselves to find out what some of those might look like. And so I think some of that challenge has been more around the process and coming to terms with the fact that actually this is going to be a different way of working and one that we will evolve and build collaboratively with one another. So I think that has been it's been interesting, but it's definitely been at the forefront of our mind to not stop to challenge some of that old way of working, really, to make sure that we have got that co-production promise embedded. I think there is a kind of realism about when we can achieve co-production, and I don't think we get co-production built into everything we do, and I don't think that's practical to do either. But we have definitely made sure that when it comes to building the model and understanding the network and responding to need, that we are working with children and families themselves to develop that. I think because of that, it's made it probably more challenging in terms of the speed at which we're going at. Because we are obviously, and I suppose you bear some of the scars of this, Phil, because you went through the co-production promise for what I think felt like longer than 12 months, actually. So I think there is something around kind of working with people to continue to hear their views, challenge back, and build something that I think we can all get behind. That being said, I do think the partners have really embraced the co-production promise. I do think there are some examples of practice across the system that have been really fantastic. And I do think that some of the feedback we got from some of the Family Hub launch events actually is already starting to bear fruit in terms of helping us to understand where we need to prioritise first from a children and families perspective, which I'm sure will provide some challenge back to the partnership in terms of making sure that it reflects what they need it to. And I'm not sure if there was a second part to the question I might have missed.
0 to 5s, moving to 0 to 9.
Yeah, so I think we're very conscious that Sure Start Children's Centres were built on the back of 0 to 5 agenda, and so you can't move away from the fact that the buildings are, particularly in some of the smaller sites, they are built and made for little people. So I think that's why the network is so important. So we've got really good, strong partnerships within most of the districts, and as part of that, we're talking to people about the Family Hub network, and by that, we've developed, based on the national model, a Family Hub network kind of toolkit really that helps people to identify what they'll need to do and be able to provide or evidence as part of the Family Hub network. And we're hoping by doing that we're being really clear and open and transparent with people around what the ask is, but also giving a broader range of people an opportunity to be part of that Family Hub network. So I know, for example, we've spoken to some of the districts and borough councils about their offices being used for part of that work. And I know, for example, Skivvies have been helping us to identify community venues that might be part of that network. So at this moment in time, we haven't got anything that kind of says, you know, the children's centres will be it, as in they will be a 0 to 19 building. It's more about how we establish that network of support so that children and families can get that help and support wherever they go. And the thing that remains consistent really is about that information, advice and guidance, and the not passing people around the system, but the integrated way of working. And again, that's what we're getting some of that Family Hub network to sign up to. So again, I suppose an ask of us is to make sure that people are talking to people about that Family Hub network, talking to them about their willingness to be participate and be part of it, but also to provide some challenge back to us where you might not think we've got that quite right.
Yeah, 3 if I may, Chair. So 1 on infant mortality, 1 in smoking in pregnancy, and 1 on the first 1,000 days. So infant mortality, our infant mortality rate is higher than we might expect for a county of our sort of population. And I believe that's driven by particularly high rates in 2 of the districts and boroughs. So the question is, what insights do we have into why that's the case? And what does that lead us to do in terms of interventions to reduce infant mortality? Smoking in pregnancy, so the reduction in mothers smoking at birth, certainly very welcome. If you look at the stats from the service, only about 10% of mothers who are smoking at booking are actually setting a quit date. So we're losing 90% of women. So the question is, what can we do about that to try and get more people through the service? And the last one on the 1,000 days, is what outcomes are we specifically trying to achieve from that service, and what's the evidence base for the interventions that we intend to deploy to achieve them?
Would you mind if I took them backwards to frontwards? So the first 1,001 days isn't a service. The first 1,001 days is a requirement of the Family Hub model. So nationally, the Department for Education have set that they're clear, you know, that they want people to have family hubs. As part of that, they want parents to have easy access to what the pathway looks like. So it was started by a piece of work that MP Andrea Ledson led on, and it really did spend a lot of time trying to understand from a parent's perspective how they received the system of support. And so the first 1,001 days pathway is really about making sure that from a parent's perspective, it's really easy, clear to understand how you might interact with a range of different professionals that might be supporting you in that earliest time. And as part of that, it's to be clear as well to the partnership around our roles, relationships and the outcomes that we expect to achieve as a partnership in that space. You know, there is midwives, health visitors, community organisations, you know, networks within your own community, a range of different people that are kind of working with and alongside parents, and they found it really tricky to get some help and support when they needed it. A really practical example we had coming through the Safeguarding Board during COVID was that one parent knocked on 39 doors before she got the help that she needed. And so really that pathway is about helping them get timely access to help and support that they need. It's also something we're measured on in terms of inspection around how we get people to early help and support. So it's not necessarily a service per se, but it's about making sure that we've got that suitable pathway for people at the earliest point in time. In terms of the smoking and pregnancy service, I would have to go away and have a conversation with Louise Andrews-G around the dropout rate in terms of the 90%. But I do think there have been considerable improvements made in that service that are trying to encourage as many people as possible to quit. And making sure that service is available to those who will benefit from it most. So I'll come back on that with some specifics, Richard, if that's okay. And then the infant mortality, I wonder, Nicola, if that's something I could pass over to you.
Yep, so I think that's really part of the steering group's action plan, Richard. So I think there's recognition that the infant mortality is a really complex agenda, and it's multifactorial in terms of the levels of risks and modifiable factors. Some of that varies around levels of deprivation, different ethnicities, etc. So I think that's something probably we need to take away and have a look at and come back to you in terms of specific actions that we need to take in those two districts. But I'll certainly raise it with the chair and make sure that that's something we can feed back on.
I think on that last point, Nicola, that you mentioned the question about the two districts, you know, and if they are, you know, if they're significantly higher than other areas, then you know it's probably fair to say that if we can make impact in those areas, it has a good effect on the whole county as well, because you know sometimes whole county figures positively or negatively don't always show what's happening in different areas. So I think that's a good point. Any other questions on this subject at all? Last chance before we go around the room. Okay, thank you very much both. And I think most new parents would be able to write a book about what they hadn't been told about bringing up children. I could probably still do it now 30 years later. So thank you both. Okay, if we move on to the next item on the agenda then, item 3, which is from Health Watch here, Year 2 Progress Report. Baz, over to you yourself.
Yeah, thank you for that, Chair. Yes, today I'll be giving an update to this board on our annual progress and our annual report. There is a report being submitted already for this. I'll take that report as read, and I will be using these slides just to pick up some of those key highlights. Okay, thank you. So yeah, I just want to start with that, how we've been, as a Health Watch, trying our best to integrate into the system as a whole, whilst maintaining our independence as a crucial part of our function. It's important to highlight, as we go through these slides, how important that's been, and hopefully I'll be able to demonstrate that. Sitting within Support Staffordshire as our host organisation has been really beneficial. We've been able to use the very many members that Support Staffordshire already has, which has really supported us. We've reached out to those members. We do have now 53 members who are directly a part of our Health Watch intelligence network, which is growing. We also have a further 17 PPG groups who are also agreed to be a part of that Health Watch intelligence network. And also we have an organisation called Sherpa. This stands for Staffordshire and Stoke-on-Trent and Shropshire, Telford and Wrekin Health and Care Research Partnership. Just to, yeah, it's a bit of a mouthful. Just to really get that broader insights and reach across the border with Staffordshire residents as well, just to see if there's any trends and themes. There we go. So as part of our impact and engagement, we have engaged with just under 3,000 people across Staffordshire who have engaged with our Health Watch to share their experiences of health and social care, with a further 6,000 who have engaged with us via social media, and 14,000 via our website visits. We had 800 residents who we supported directly with advice information. This is both through our free phone number and our digital means. And also we do the signposting with partners where that is appropriate. We currently have 18 volunteers, of which 7 are also part of our Health Watch Advisory Committee, who help us with our engagement and to promote Health Watch. They also help us to carry out our statutory functions, such as enter and view visits, and collecting experiences of residents and supporting people to share their views. One of the obligations we do have statutorily is to work with Health Watch England as our national partner. We are under a statutory obligation to share data insights on a regular basis with Health Watch England. In Staffordshire, we agree to do that on a monthly basis to keep that as timely as possible and up to date for Health Watch England. Some of the, what this does is all local health watches are feeding this back up towards Health Watch England to build the national picture. And what Health Watch England will then do is look at these themes nationally and then come back to us with campaigns that they want to focus on. And some of these campaigns they have focused on is around social care, cost of living, maternal mental health, GP access and NHS dentistry, just to highlight a few. And just to home in on one of these particular ones, for example, NHS dentistry, they reached out to us as a local Health Watch, asked us if we could support this particular campaign, which we agreed to do. We put this across our comms and engagement activities. We were able to feed back directly to Health Watch England with over 90 pieces of experiences of patients and residents, and this contributed towards an overarching 3,000 national patient experiences. Health Watch England then put that in report format, took that information back to the Parliamentary Committee on NHS Dentistry to really have that impact at a national level. Then what Health Watch England does do is give us that feedback as well, and we can then use some of those recommendations locally. Again, as part of our way of working with the ICB itself, we have been sharing data insights. We have been very active to work on many different areas of work that is really, really needed. One of those being a focus on health inequalities and the core 20+. So this is the 20% most deprived people. This could be those that could be homeless. It could be those from seldom heard communities or those in neurodiverse conditions. It's just really important to highlight that under the Health and Care Act 2022, there is a statutory obligation for the ICBs to have a 5-year joint forward plan and to review this on a yearly basis. In the year of 23 to 24, Health Watch has been supporting to review this as well as being an active member in that. And it was really reassuring for us to see in their joint forward plan that Health Watch, as well as other partners in the VCSE, were mentioned as key partners for them to work with to really get that good patient experience fed in to how they design the services. Again, part of the Health and Care Act is that ICBs are obliged to hold and have systems quality group meetings, so these must take place. reason why I don't just particularly highlight this here is just to say that at this meeting, Health Watch will do a presentation and a report to pick up some of the key highlights. So we're picking up themes, happens on a monthly basis. CQC is also present. We also have local authority representatives, and not only is this chaired by the IC, but we have also the various trust partners that will attend and give updates and share information and data. What's really reassuring here is that when we do present that patient information back to and concerns back to the ICB, they will chase it up, they will follow up and contact me back or one of the team members to say, oh, can we chase this up, or they found the right person for us to speak to. And just some of the key things, key things we've been presenting back there around GP access, neurodiversity, those discriminated sometimes when they try to access, especially primary care services. We've got young people in mental health services, and again, as mentioned, those seldom heard communities, but we've also given feedback around non-agent patient transport, kidney dialysis, and more. So again, working with partners within Staffordshire County Council and sharing information and data. We have been working on adult social care, supporting the County Council's commissioning strategy for older people to stay in their own homes and live independently for as long as possible. We did do some work jointly with Staffordshire County Council to reach out to care home residents. The aim of this particular project was to find out what residents feel is important to them in a care home. We, again, just thinking about the earlier conversation here, we reached out to, in each district, we try to distribute that we had a visit to at least 2 or 3 care homes per district to get that geographic cover and to ensure we're getting that widest possible picture. We had over 300 patient responses, and just say they were mostly dementia patients, so it was mostly one-to-ones, though there were some surveys there. But again, we got some really, really good information. This was fed back to Staffordshire County Council colleagues, and this was to help them to inform their future tenders and deliveries for future services. Now, I just wanted to pick up, in the annual report itself, it's got many mentions of many boards and really interesting and good meetings that need to happen. But these 2 particular ones here, so the Quality and Safeguarding Information Sharing meeting, the QUISM, which is chaired by Andrew Jeps, and then the Staffordshire and Stoke-on-Trent Safeguarding Partnership Board meetings. And again, the key theme through there is the safeguarding bit. And it's always very important for us as a Health Watch, because we recognise one of the core reasons why what underpins us as well is recognising when things go wrong, it's usually when patient voice is not being heard and when services are not talking or not sharing data and information. And what these 2 particular, I'd call it spaces, give is partners the safe space to be able to discuss things that they may struggle otherwise, to really get to the bottom of things and then hopefully disseminate that good practice back into the system as a general. So just moving on to the next one. So again, as a Health Watch, we are set up as 3 primary areas. One is feedback from patients, which we then aim to feed back to the right people to make those decision makers and commissioning leads. The second part is information, advice and guidance, and the third being signposting. So we are at the moment, working with our partners, especially with the PALS team and Assist, and trying to co-produce a leaflet just to get that increased visibility collectively, but to ensure that that information is always up to date and we're working together well. And then just to also add, we do have our e-bulletins and web page that helps us to distribute what's going on in the system and any patient concerns. And just to then also finally add, we have our powers for enter and view, and just to highlight some of those enter and view areas that we have been focusing on have been around mental health, chronic pain, community intervention, neonatal and maternity. And again, there are others, and if you would like to see those reports on there, they are on our website. So looking ahead for the next year, we will continue to build on our Health Watch intelligence network, and working with partners is crucial to how we want to be working and feeding that information back from patients. We will be highlighting those key themes that are emerging both nationally with Health Watch England as well as locally with both Staffordshire County Council colleagues and health colleagues in the NHS. We will utilise, and well, we are now working on our priority areas with our 3 deep dive areas. So this got to create the overarching patient journey. So we've just completed the first deep dive of the 3, which is the 999 calls and ambulance services. We have been working with colleagues from the Healthcare Overview Scrutiny Committee on this, and with West Midlands Ambulance Service. Dave, thankfully, really led on this and spearheaded ahead with it, and it's really come out well, and has been working really well with Vivek and the West Midlands Ambulance Service. And I know that that's been given back to West Midlands Ambulance Service, and they are taking that to their board to share those recommendations and the findings. And again, as we move now into our second deep dive about admission avoidance, we're going to have a focus on how well systems and people and the different organisations are talking to each other to help support admission avoidance, and around virtual wards and their efficiency. And that will hopefully then take us into the third deep dive around hospital discharges, where we already started to talk to ICB colleagues as well as Staffordshire County Council colleagues. And I think that will end the presentation, and we'll take any questions.
Yes, thank you very much for that presentation. Okay. Any members of the panel, any questions at all? Richard?
Not a question, Chair, but just to say that we've really welcomed Healthwatch's input into county council functions, particularly social care. I think they've provided us with a really valuable source of feedback, which we've used to actually enhance services. So thank you.
Thank you very much. So thank you for that. If there's no further questions, we'll just move on to the recommendations then. And the board is asked to consider and comment on progress made by Healthwatch Staffordshire during year 2 of the current contract. You've had that opportunity, and I'm sure that we note further detail in the presentation for 23-24 annual report, and to consider future joint working opportunities with Healthwatch Staffordshire in support over the next three work plans. Okay, unless anybody's not in favour of those, I'll take those that we're happy with those recommendations. So Bas, thank you very much. Next item, I want to go back to something I missed, and that was the recommendations for the first item, the Health in Early Life Priorities Progress. And that was the board was asked to note the progress being made by partners in Staffordshire regarding health in early life. And I won't read out the list of the eight there that can be seen in the in your packs. And then secondly, to consider the requirements for the Health and Wellbeing Board to receive an annual report update from the Child Death Overview Panel, which I think I would welcome, and I would hope. And I think we're getting some nods there. So thank you for that. Okay, so we'll then move on to the next item on the agenda, which is the Better Care Fund. And Rose Newconnell, you want to come and sit up here? Rose, welcome. Sorry? The one that looks like a sort.
Okay, so afternoon everybody. I'm going to give you a brief update on the Better Care Fund today. Just a couple of things to note from myself. So firstly, in terms of the current 2-year plan, the requirement to complete quarterly returns recommenced last year after a bit of a break during COVID, and subsequently we've submitted our report for quarter 4 for last year, and this has been signed off by the chair, and also recently we've submitted our quarter 1 report for this year, which just required an update on our discharge grant spend and some of the outcomes that we've achieved. In addition, whilst this BCF is now a 2-year agreement spanning across 23-25, there was a requirement this year to submit an updated template for 24-25, which we have done. We didn't make any changes in Staffordshire, and our expenditure and schemes remain the same as we originally planned, so the board will be aware of what those are. And as is required by the governance, these have also been signed off by the chair before this was sent off. In terms of DFGs, as was the case last year, we've received additional funding of around 900 grand for Staffordshire. This has been passported to the districts, and there's also been a separate piece of work feeding into the Leaders Board in Staffordshire in terms of reviewing DFG performance and the use of DFGs moving forward. So If you did want any information on this or any further detail, I'm happy to get the DFG lead to bring something back on that for the next board update. In terms of an update on the the ICB discharge grant, which forms part of the Better Care Fund, as was noted at previous boards, Staffordshire County Council, we didn't agree on how the grant had been apportioned between Staffordshire and Stoke. The percentage split for last year was accepted by the council on the understanding that it would be reviewed ahead of this year, which unfortunately hasn't happened. So we haven't agreed to the funding split that was submitted and that's been implemented for this year, but we haven't escalated this to NHSE on the understanding that this isn't setting a precedent for Staffordshire for any future splits, and that the ICB will review any methodologies moving forward ahead of any further grant allocations which they've committed to do. So I think it's also important to note that the BCF conditions of the grant, they're very clear, that in terms of how they're spent, how they're allocated, how they're agreed, we have to agree them jointly between the local authority and the ICB. So moving forward, I think it's very important that we make sure that we're compliant and in terms of joint working, that we all agree this moving forward. Also wanted to just briefly update you in terms of the Section 75 this year. We've now had it signed by the ICB and sealed by the council. I think it's been a great step forward this year because we've managed to include a number of joint working schemes under one agreement. So, for example, the ICB commissioned the council to source home care health tasks on their behalf. We have Section 117 aftercare in there, and also funding for health needs in care homes. So now that they're all managed under one contract, this helps with reporting and with managing it through one joint commissioning board. So that's great. Just in terms of future planning, we've started a review of all the Better Care Fund schemes in order to plan for next year. So whilst we don't have any guidance come out yet on what the requirements will be next year, we wanted to get ahead really. And also because we've got some schemes in the Better Care Fund that are propped up by non-recurrent funding, which we're not certain on this, but we expect that it will end at the end of March. So we need to plan ahead for that. So we've started with a desktop review, where we've just as the name goes, we've done a desktop review of all the schemes. There's over 60 schemes in the Better Care Fund. All of the ones that are funded by Staffordshire County Council BCF elements, they are statutory, so they will be out of scope for the review, and they fund things such as home care, residential care, Care Act assessments, safeguarding, social work, etc. So it's very important that they obviously stay in place, so they will be out of scope. The ICB have identified, I think, around 30 schemes that they're proposing to be reviewed, and then the next step for these is we've got working groups in place that will now commence the review. So each scheme, we're going to review what outcomes they achieve, do they provide value for money, what would be the impact if those schemes weren't continuing, for example. But it's important to note we won't be making any changes to any of the schemes without Health and Wellbeing Board approval. It's in its infancy at the moment, so I can't give you any detail on that, but the next update that we bring will hopefully be some further info on the review and present some recommendations for you. And then finally from me, I previously noted at a couple of the boards that we'd been successful in receiving some urgent and emergency care funding. There was over £1 million allocated to Staffordshire to support winter pressures. So I've given a little bit of an update in the paper on the schemes, and that's just for information, really. That's it from me. Any questions? Thank you.
Rose, thank you. Richard, is there anything you want to add at all before we ask for questions?
So probably just to highlight that over the last few years, the BCF has been relatively straightforward for us. There's been a core amount of funding which has been pretty consistent, which has allowed us to maintain services and for them to mature and have a real impact. And we've had additional funding both through the NHS and the County Council that we've used to invest, particularly in a range of urgent care services, admission, prevention, discharge facilitation. The BCF is about to become much more difficult, and that is because about 15 million of funding will come to an end, or seems likely to come to the end on the 31st of March, and because the broader funding environment is getting much more difficult at the same time. So I suspect that that may present us with some tough decisions, perhaps next time we convene, and we might need to make sure we've got adequate time both at the meeting but possibly in the run-up to the meeting to get our heads around those. Thank you.
Yeah, thank you for that, Richard. Very sobering thoughts. Anyone, any questions or any comments that they want to make on that at all? Okay, thank you. In that case, that's, so the board is asked to note the 23-24 end of year report and the 2024-25 updated BCF plan have both been submitted, and that Staffordshire has received an additional 907,989 allocation in 24-25, a total of 10,913,000. The other recommendations are there to be read. I take it everyone's in favour of those recommendations. Okay, I'll take those as read then. Thank you very much. So go on to item 5 on the agenda. Oh, no, item 5, the ICB annual report, which I understand we're not taking today, are we? And then item 6. Then back to yourself, Richard, for your public health annual report.
Thank you, Chair. So this is this year's Director of Public Health report, and I've chosen to focus on ageing. So the population in England and Staffordshire is ageing pretty quickly, actually. Since the millennium, the number of people over 85 has pretty much doubled, and over the next 20 years it's going to double again. And meanwhile, over that 40-year period, the number of working age adults is going to remain more or less the same. And that means that the ratio of working age adults to pension age adults is going to fall pretty markedly, even taking into account the increase in the pensionable age. I think that's going to have some pretty profound consequences for society, for public services in general, and for health and care services in particular. The report includes what are essentially back-of-the-envelope type calculations about the impact on health and care services. But I think it's something in the order of about 600 million additional funding, and about 20,000 additional staff will be required by 2041 to maintain services the way they are. And it's not obvious to me where either of those things are going to come from. So we have a new government which is signalling an ongoing and possibly intensifying period of austerity. And in terms of the staff, of course, the number of working age adults isn't actually going to increase. So it would mean that people stop doing something else and start doing health and care. Again, it's certainly possible, but it's not obvious that that trend is happening at the moment. There is therefore a risk that health and care services either run out of money, or they run out of people, or they run out of both. That's the bad news. The report does present a bit of a silver lining, which is that I think there are 3 ways we can mitigate that risk. So the first one is a genuine focus on prevention to try and extend the period of healthy life expectancy. If you look in the report, you will see that there's a considerable gap between healthy life expectancy and actual life expectancy. And if we can reduce that gap, we can reduce the number of people who are dependent on health and care services. Secondly, it's to rethink the way we care for particularly the very frail and elderly. At the moment, we have a model of very intensive intervention right up until the point of death. And I think we would be better served by focusing on dignity and compassion rather than extending life beyond a certain point. And thirdly, I think there are ways that we can explore where technology might complement the health and care workforce and just free up a bit of staff time and make things more productive. There are then 7 recommendations in the report, which I won't read through. And really, I've brought it here today just to provoke discussion, debate, and to get your views. Thank you.
Yeah, and Richard's last 2 comments fit into the recommendations, is for us to consider the implication of the report and also to promote this in our organisations and networks. So, comments, questions? Got free.
Yeah, thank you for that. It's just some of the work we've been doing and the meetings we've been attending with the ICB, and there is a lot of work going around palliative end-of-life care. We know as well, working with patients, that still, though there is the intention and the move to help support patients to stay at home longer and die at home as well, as opposed to in hospital again, that still doesn't happen fully. I know there's a move towards, I'm just thinking about what you just said there, and it's something that we're going to try to work in within our deep dive areas, just to see where we can pick up, where those efficiencies can be made as well, just to contribute, if that's helpful.
Yes, so I think the intention for a more compassionate approach at the end of life is certainly there. I'm not sure that I'm seeing the delivery right now. So we still have the about 1/4 of people who are in hospital are in their last year of life, and about half of all deaths occur in hospital, and that isn't really changing, not in a very significant way. So I do think Health Watch may be able to play quite a significant role in changing culture and practice, trying to help practitioners reflect on how they manage people as they get very frail and elderly and towards their final years, and what is it that people actually want when they get to that stage? You know, is it lots of life-saving interventions, or is it being able to die at home with friends and family around them?
What is the County Council doing to promote more development of extra care facilities, so that people are not so isolated at home, perhaps maybe living at home and frail and elderly, but going into a facility which would encourage more social interaction and, you know, some limited support?
So for the purpose of this report, I'm not the County Council spokesman, but I will put on a different hat. And what we are doing is trying to signal to the market how much extra care we are likely to need, and to try and stimulate development of that. Obviously, the County Council itself doesn't build extra care facilities. All we can do is try and influence people to build it by providing reasonably accurate statements of demand. We have got a range of extra care facilities already, and certainly for those people who are eligible for council-funded care, it historically has not necessarily been a natural choice for people. So it's something that we've pushed, and people have actually said, well, you know what, I'd prefer to stay in my family home or go into a care home. So we probably do need to do more work there to try and help people to understand the potential benefits and bring it into people's thinking in a way that it perhaps isn't at the moment.
Has the County Council published its 2024 extra care assessment, indicating what the demand is for extra care, so that in fact the market can respond to the likely demand for extra care in different parts of the county?
Not yet, due later this autumn.
Okay, so that's going to be published and will be made available to the public generally?
Yes.
Thank you.
I just wanted to support Richard's call that we look for improved prevention to help older people to live at home and to have healthier lives in their older age and to need less direct health services. I was discussing a report yesterday around Cannock Chase's council housing stock. Cannock retains its own housing stock, and we're spending an increasing amount of money on disabled facilities works to enable people to remain in their council house. And part of the reason that we're doing that is that the number of tenants who are now of an older age represents about 70% of our tenants. So we're largely providing social housing for older people. There's nothing wrong with that, but I think it gives us an opportunity, and it's one of the things we were talking about yesterday, to work with tenants on preventative measures to enable them to live safely in their homes, perhaps to need less disabled facilities works, which will save us money and ultimately to require less NHS care and to live their old age in health. But I think there's a lot of work to do, and I think if we have that mindset across a wider range of services, maybe we can make some impact on that. Thank you.
Thank you, Jim. Very interesting points. Lynn?
Thank you. Nothing to disagree with in those 7 recommendations. Certainly, you've given me a bit of a, probably knowingly, an open goal, Richard. Number 3, around that investment, commitment resources for prevention initiatives. And there's many reasons why that's proved difficult over the years. I guess I'd pick up on a couple that is perhaps an opportune time with the new government centrally. Those longer term funding commitments, particularly for the NHS, it's extremely difficult for our NHS colleagues to prioritise things that pay off too far ahead when they're under annual budget pressures. And the second one that sort of goes a little bit hand in hand with that, which is trickier. So the first one, there's an opportunity to put pressure on our local MPs to apply that pressure to government for those longer term settlements. The second one that I think is a little bit trickier and almost is a bit of a taboo, I think, about talking about it. There's a bit of a disincentive if you're at a very senior level in the NHS to spend time and effort in your career on things that are not going to pay off for a very long time. You're kind of doing in your own career by spending a lot of time and effort by doing things that are not going to be immediately attributable to you. So if you can fix things that just get more people out immediately, you'll succeed and move on in your career. If you spend a lot of time and effort investing in things that are way down the line, a decade or more, and are actually going to help all of your colleagues in other organisations, but not necessarily be attributed immediately back to you, I think there's quite a significant disincentive in that, in how we're sort of rewarding some of our senior leaders, and not explicitly, it's sort of implicit disincentives, I think, that we need to have a look at. There's very little incentive for a hospital chief exec to do things that results in them shrinking the size of their hospital. They want to be bigger and more and move on to a bigger trust. And why would you do things that means you're going to close a ward? Because that makes it look like you run an unsuccessful organisation. So, and I'm being a bit deliberately provocative there, but I think there's some real entrenched, difficult cultural things about making that prevention shift.
Thank you. I was hoping I'd got another 10 years working in Staffordshire and Stoke, so I think I've got an incentive there, plus I live here, so an added incentive. I'd really welcome the focus at the around prevention and healthy ageing, and I think we need to adopt that as a system and tackle the problem at scale between all of our organisations, so it becomes the absolute focus of everything that we do. It is considered something that happens in the future, but I think we can start measuring it, we can start demonstrating that inputs turn into actions that turn into outcomes. We need to think about how we do that together. Talked to Claire and Richard before about the outcomes framework we're developing that will be a sort of a short to longer term plan that will have funding wrapped around that. It's only around 1.2 million for Staffordshire, I think, but actually if we can coalesce around a common goal and build all of our resources around delivering the prevention agenda, I think pretty soon you'll see that we can actually make some change happen. So I know we've talked about having the evidence base, Richard, but I suppose it's quite an unfair question I'm asking you. I won't hold you to it, but I'm interested to hear, if we did focus on prevention at scale across all of our organisations, where would we get the biggest bang for our buck? Would it be a clinical pathway, or would it be one of the wider determinants? Where do you think we should start?
So in terms of health outcomes, the wider determinants influence about 80%. So it is going to be wider determinants.
Yeah.
The problem that the NHS is going to have is that your ability to invest in that, I suspect, is going to be very constrained indeed. So I suspect you're going to be looking more about what you might call secondary prevention and what you can do within clinical services. I think the other steer I might offer is the NHS needs for this to be a whole system endeavour. The risk is it becomes a small bit of the NHS that does prevention on a budget of 1.2 million, which is 0.1%, isn't it? No, 0.03%. and the rest of it just carries on as normal. If we're serious about this, we need a change in clinical culture and practice right across the NHS. And that means that a lot of doctors and nurses will have to unlearn all of the behaviours that have been inculcated over years and decades and learn a new set of behaviours. And as you might imagine, that is going to be pretty hard.
Yeah, I suppose it's very much about prevention in this. Is and prevention in helping with ageing starts particularly early, isn't it? And people at the time they need to be thinking about that, and probably absolutely it's the last thing on their on their mind until potentially that it's getting more difficult. Anyway, any further questions on Richard's report? I think we've certainly done the recommendations in there, so thank you very much for that, Richard. In that case then, we will move on to item 6, which is the Staffordshire and Stoke-on-Trent Health Protection Quality Assurance Annual Report. And I take it that you are Beth. If you could introduce yourself and then you can go into your report, please. That's it.
Okay, brilliant, thank you. Hi, I'm Beth. I'm Infection Control and Outbreak Management Lead at Staffordshire County Council Public Health Team. I've come here today to bring to you the Health Protection Quality Assurance Annual Report. So this is the first annual report that we've produced, and it was produced by the Staffordshire and Stoke-on-Trent Health Protection Quality Assurance Group. The Health Protection Quality Assurance Group consists of ourselves, Staffordshire County Council, Stoke-on-Trent City Council, ICB, UK HSA, so UK Health Security Agency, Civil Contingencies Unit, NHSE, colleagues from district and borough environmental health teams. So it very much is a joint partner report. The purpose of health protection is to prevent or reduce harm from communicable diseases and environmental hazards. And Staffordshire County Council has a key role in governance and planning of health protection across the local health system by the statutory DPH role. So I think it's worth highlighting that we're not the commissioners or providers of a lot of the services, health protection services within the report. But the report does provide an overview of key health protection highlights from 23-24, including partnership challenges, achievements and recommendations for future areas of focus. So I know everyone's got an action-packed agenda today, and I don't intend to take up a lot of your time because you will have had a copy of the report. But I do think it is worth just highlighting an overview of the achievements, particularly the Memorandum of Understanding. So that's on page 4 of the report. The Memorandum of Understanding on Management of Infectious Diseases has been used as an example of best practice across the West Midlands. It very much sets a framework for how we operate between partners, highlighting roles and responsibilities and specific pathways for the effective control of infectious diseases. The MOU has already achieved significant improvements in local preparations for and response to infectious diseases across Staffordshire and Stoke-on-Trent. And I think leading on from the MOU is the CCU support in terms of the review of infectious disease pathways. So the Civil Contingencies Unit have coordinated a number of tabletop exercises over the past year, bringing partners together and to understand any emerging risks, any new guidance, and making sure that we've got the pathways in place to respond to outbreaks of infectious diseases. In addition to highlighting the achievements, I think it's also worth just highlighting the priorities that we've identified following this report. So the priorities I've identified are on page 27, and we've used those priorities to inform an action plan for Staffordshire. So the priorities that we've identified are vaccination inequalities, so how we can address area and cohorts of low uptake, particularly focusing on those immunisations where we are lower than where we should be in terms of uptake, so MMR, booster, HPV and shingles we've identified. We're also going to be doing a focus on screening inequalities. And again, based on the data-informed approach, we've selected cervical screening and diabetic eye screening to focus on. We've also recognised the need to carry out a needs assessment to help us improve the understanding of health protection needs across the local population. And in addition, we've recognised the need to look at our migrant health response, which we appreciate is a constant changing landscape in Staffordshire. And lastly, we recognise the need to look at our community infection prevention and control provision, reviewing what local provision we currently have in place. And those are the priorities that we're going to look to develop into an action plan for 24-25, very much working with system partners. Any questions?
Thank you very much for that. Any questions, any points anyone would like to raise? Okay, you've got a particularly light. Oh, sorry, Gary.
Sorry, Chair. It was a fascinating, interesting read. I was intrigued as to the one that sort of was out of kilter with the others was the air quality one, in that it didn't feel the same as screening and vaccination. And then I also noted at the end that it's no longer a priority, and I wondered if there was any sort of explanation for that, as to why it's in there in the first place and then why it's no longer going to be a priority in the future.
Isn't my area, so apologies.
Is that
I
okay
might be
if I
able to
take
answer
that? Is
better.
that all right? So I think that's probably not quite what we meant, so we perhaps need to reword if that's how it's coming across. So it's not that it's no longer a priority, it absolutely is still a priority. Health protection is a really broad area of work, and it includes environmental hazards as well, and things that impact on the public's health that aren't necessarily typical sort of behavioural lifestyle things or healthcare related things. So it's the breadth. So all the work around Wally's Quarry and the sort of air pollution related to that, anything to do with air pollution related to traffic, all those sorts of things have an impact, and that's included in that sort of broad umbrella term of health protection. So in terms of what that group will look at, it will continue to have an assurance role around air quality, albeit it's kind of alongside the dedicated air quality project groups that exist, so it won't replicate or replace any of that work. So it will be still part of the work programme and sort of the agenda of that group. The priorities that are identified within this report are really sort of specific programmes of work or bits of investigation we need to do where we've potentially identified that we either don't have enough information or we feel there are significant gaps at the moment. So that might be in a particular screening programme where we think uptake's very low amongst a certain population, for example. So that's why it's always been in there, and it will continue to be in there, if that helps. Okay.
Matthew, and then Lynn.
So just say thank you, Beth, for presenting that. I certainly was one of a number of contributors to this report, and I think I'd just like to highlight there's been a number of mentions of prevention today, and certainly within the action plan that we're looking to develop, we're really looking to strengthen that. The partnership that we've formed in health protection has recently had to respond to situations around pertussis, measles, we have mpox at the moment, and actually through work around vaccination, screening as a mechanism to prevent cancer and complications of diabetes. These are strong evidence-based public health interventions that support prevention, and yet we do have challenges within our geography. We've seen declining MMR vaccination over the past decade, for example. So we've recognised the challenge there, but I think just as a point to add, we will certainly be looking at the kind of support of all partners as we look to take forward this joint health protection action plan to try and prevent future pressures from infectious diseases and cancers in these other areas.
Thanks. I was going to say exactly the same. It's a really, very specific focus on prevention there, isn't it, that we can build programmes of work around, and certainly we've got experience of working together as part of COVID and targeting inequalities. So in terms of our response from the health side of it. We're absolutely committed to working together on this agenda.
Okay, thank you. And there's nothing. Oh, Claire, go on.
Sorry, can I just make one final comment? It's just a big thank you really to Beth in particular, but to everyone who contributed to the report. I know it was a huge amount of work, very painful at times. Everyone will know that working on a partnership piece of work like this is very time consuming, and it can be quite difficult to get everybody to contribute within a sort of time frame. So well done for getting it to this point and getting it over the line. I think hopefully it'll be a bit slicker next time, but I think it's a really useful starting point for us in terms of the sort of outputs and the product of that group, which has achieved significant things actually, and some of the work that group's done has been recognised regionally as best practice, and we've sort of been asked to share that with other areas, particularly the MOU, but some other things as well. So just a big thank you and a well done, I think.
Okay, thank you very much, Beth. Thank you very much for that. And as I said, noting that report is the recommendation on there, which I think we have done. Okay, which moves on to the next item on the agenda, which is Staffordshire and Stoke-on-Trent alcohol strategy. And I understand, Matthew, are you presenting that?
Yes, that's myself. So for those of you that haven't met me, my name is Matthew Misson. I'm a consultant in public health. I work for the Integrated Care Board and University Hospital North Midlands, but important to say in this capacity today, I'm very much here on behalf of the partnership steering group that has led the development of this strategy. And that's been jointly facilitated with the Police, Fire and Crime Commissioner's Office. So this is a strategy that emerged as a priority from the Integrated Care Partnership strategy that was developed, and very much reflective of the fact that Staffordshire and Stoke-on-Trent's population see significant impacts from alcohol harm. Just to talk through the approach that we have taken as a partnership, a starting point was arguably to make a case for why look at alcohol specifically instead of drug and alcohol jointly, as we have typically done in the past. I'll talk briefly on that shortly, but then very much go through a process of developing a partnership around this, reflecting that actually, due to the multiple impacts of alcohol across society, it's something that no one organisation can arguably address in isolation. Very much need for a whole partnership approach to that. We've delivered a comprehensive alcohol needs assessment, which has provided some very useful evidence and insight into how alcohol is impacting within our population. And in July, we hosted a large system workshop, which was attended by in the region of 50-60 representatives from across Staffordshire and Stoke-on-Trent, including kind of Health Watch and representatives of individuals that have been through alcohol treatment services and recovery. At this point, we're very much in the process of writing the strategy, and I'd want to take today as an opportunity to very much engage the board on some of the priorities that have emerged from the strategy development, seek feedback on some of the priorities, and certainly look for support as we go forward to planning and implementation of the strategy. So one key question that we've often had is, why focus on alcohol specifically when often drugs and alcohol are looked at concurrently? What we do know in terms of the national picture, and this is reflected locally, is there is a significant number of people that consume alcohol to harmful or have alcohol dependency. Despite having very effective treatment for alcohol, actually the significant number of people with alcohol dependence are not in treatment, so there's a lot of unmet need there. And reflecting this, what we are increasingly seeing is a lot of alcohol-related illness and increasing alcohol-related mortality. But I would say that is very much the canary in the coal mine, and there's a lot of harmful impacts across society more broadly that we see from alcohol. So there's a question of how we respond to that. Our needs assessment has provided some very useful insight in terms of the local context. It looks at both Staffordshire and Stoke-on-Trent, but to just give some highlights, we see significant impacts from the availability and harmful levels of consumption of alcohol within our communities. Importantly, that is not distributed equally. So we see higher levels of alcohol consumption within our population aged 44 to 65, increasing impact from excess alcohol consumption in women, and we see this very much more within our more deprived communities. When you look at our social care system, alcohol is involved in a significant amount of social care activity, both looking at families where alcohol misuse is present, but also domestic abuse, and looking at our older population where alcohol may be contributing to early onset of poor health and disability. And there's a raft of other areas that we're looking at. The council's made excellent progress in developing an integrated drug and alcohol treatment service, but what has become clear from engagement is there's a real opportunity to look holistically at how we focus increasingly on individuals' mental needs, their wider medical needs, and also their social needs such as housing, employment, to really enable people to complete treatment successfully and recover from alcohol dependency. We have our strategic principle, so go back a slide, so priorities that have emerged from the needs assessment and engagement. We're very much adopting what many will hopefully recognise as a prevention pathway. So looking at how we can work with families, children and young people and address stresses and risk factors that we know increase individual likelihood of misusing alcohol or developing alcohol dependency. There's significant opportunity around secondary prevention. So this is in individuals with escalating alcohol consumption. How can we identify these individuals at an early point and intervene in a way that stops that escalation and gets them into effective treatment early if necessary? And this is something that's typically been viewed as the territory of the NHS in the past, but what has been excellent to see is from the engagement, there's a real appetite to look at how community organisations, social care and other organisations can support what we'd describe as a making every contact count type approach. Working with Police, Fire and Crime Commissioner, there's obviously an emphasis on kind of some of the impacts within the criminal and justice system and how we can look at a more preventative approach to that and ensure effective access to treatment for those within the justice system with alcohol harm or alcohol needs. But another interesting area notably is looking at some of the powers that councils have and how they could potentially be deployed in a kind of whole system approach to alcohol. And there's good examples of good practice from elsewhere. Just to give an overview on some of the principles, we're very much looking at taking a whole life course approach, so how we can embed prevention to mitigate harmful impacts of alcohol across the life course. Working in partnership, presents a number of opportunities, looking at how we can better triangulate evidence between different organisations, share information with each other, look at how we can integrate services and pathways to support better identification and referral for treatment, but also how we can embed a kind of focus on alcohol throughout the whole of the integrated care system and in people and place strategies. Alcohol is ubiquitous across the whole of society, and is something that, you know, the strategy can deliver action on, but we will also look for other strategies, including a health and wellbeing strategy, to support some of the delivery of this going forward. So I think I'll stop there and just pose a number of questions, which I would welcome feedback on behalf of the board. So the priorities outline, it would value feedback on whether, you know, they seem like the right priorities to be focusing our efforts on. are they ambitions that would be supported by the Health and Wellbeing Board, and whether there are additional considerations that members of the board would like to see considered within strategy going forward. So I'm happy to take any questions or points around those.
That's an interesting way to finish a presentation, isn't it? To ask the members of the panel the questions, as opposed to the other way, the other way around. I had a couple of points. I think they fit in a little bit to your questions, and that is how does this strategy how does it work with the county council and what the county council has been done around public health commissioning, and on a similar thing, how does it fit into what will be the next item on the agenda, is the joint strategic needs assessment that we.
Yeah. So I'll look to council colleagues here. I think it's fair to say we have been working closely together on this as the council has been a key partner. Tony Bullock, who's kind of the lead, and his team as the lead commissioner for local drug and alcohol treatment services, has been a keen partner, and is very much leading the strategy section with city council partners on almost establishing some ambitions for what a fully integrated drug and alcohol treatment service could deliver around alcohol treatment. In addition to that, what we have been doing is looking at alcohol pathways and getting an understanding of, between the Integrated Care Board, the council and other partners, where we have strong provision in place and where we sense there are opportunities there. One that I have highlighted is around what we would describe as screening and brief interventions. So it's within NHS services, within communities, within social care. How do we arguably ask questions on individuals to identify at an early point if harmful alcohol consumption is present, and then take an appropriate course, whether that be counselling that individual or referring them for treatment, depending on what they consent to. So that there's been some more detailed work, as well as some of the more strategic, to get a sense of where we are and where the opportunities to take forward in partnership are.
Matthew, thank you. Thank you for that. Just looking at section 6 of the report that you submitted, it talks there about the partners that you've worked with to sort of get this together and produce that, and the PFCC and is part of that. You mentioned, as we went through the presentation, about licensing and things along those lines. I wondered whether you have been working. We have representatives of boroughs and districts who have responsibility in that area in developing the strategy. I mean, maybe Tim might be able to answer that question from his perspective.
Yes, so I would welcome Tim's views on this. This is something which I think it's fair to say is a starting point for discussion. What we have done is looked at good practice that is has been put in place elsewhere in the country. There are, to give some examples, there are models where I think in Newcastle under Lyme, the council have looked at how they can use planning powers to reduce the proliferation of fast food outlets within. What we see within our geography is within some communities we see a very high concentration of retailers selling alcohol, and that is often associated with increased hospital admissions due to excess alcohol consumption. So we have the evidence there. I think it is work to be done, but I certainly welcome Tim's thoughts on whether there's an appetite within district councils to explore how some of the powers that district councils have could be used to support an all-system approach.
Chair, I'm sure most districts and boroughs will be very happy to have that conversation. I think much of the focus of our licensing teams and indeed licensing committees that involve members are not so much just the number of outlets that sell alcohol, but in particular their behaviours. So in terms of making sure that they don't sell alcohol to people who are underage, and the responsibility for landlords and others serving alcohol to work with their customers and encourage them not to exceed limits. I think there's a growing recognition amongst landlords, certainly, that they have a responsibility to the wider community, and that's as much often about behaviour as about concern about people's overall alcohol consumption. But I think there is an opportunity to do further education there, and I think more collaborative working.
Yeah, I mean, I personally think it's, you know, type of thing is certainly a partnership. It needs a partnership approach, doesn't it? Because there's so many, and the diagram you produced has got so many different parts in it. And I know in a future life, when I was a police officer in the West Midlands many years ago, we tried to do a joint alcohol strategy, and we had a session there with different ideas, and we got a plan on the wall in half the size of this room with all the different factors that came into it. So I absolutely understand the complexity of trying to do things along these lines. Any other members, any questions? Richard, Claire, Baz.
Thank you, Chair. So yeah, I think the right balance in the strategy between more clinical interventions and broader societal interventions is critical. Alcohol always strikes me a bit like an iceberg. So there's a bit you can see, which is the broken nose on a Friday night or the very dependent drinker on the street corner. But much bigger is the bit you can't see, which is the insidious effect of a bit too much alcohol over years and decades, and its effect on your cardiovascular system and your more general health. So it's always tempting to focus on that bit you can see, and of course we do need to make sure we tackle that, what you might call the pointy end of alcohol dependence. But we need to make sure we balance that with efforts to try and reduce alcohol consumption in society as a whole, because we get a bigger bang for our buck by getting a lot of people to drink a bit less than getting a few people to drink a lot less. And I do think we have an open door here, because what I think I see is that the current generation of young people have a much healthier relationship with alcohol than I can remember my generation having at the same age. So I think the trend is in our favour. Thank you.
Thank you. Yeah, similar points really, and to sort of also echo Matthew's points around the partnership approach. So it is incredibly complex. I think we all know that. I think we're also at a really good point in the partnerships that we have and the sort of strength of those, and we're all kind of looking to drive the same things forward, and we're heading in the same direction. I think the progress we've made with the Consultant in Public Health Alliance, for example, this is the kind of piece of work that will fit really nicely with that group of professionals who work within individual organisations but will have a common goal and a common purpose. Let's see here. And I think there are specific elements that are very, very tricky, and so with licensing, for example, it's certainly an opportunity. It's very limited in terms of how we can influence that, in terms of arguing the case for how health data contributes to a licensing decision, having been there and tried that lots of times in my previous role in Stoke-on-Trent. But it's not impossible, and there are things that we can do, and I think what we need to build on is how we develop that evidence base collectively so that we've got a strong case to put forward to say, actually, no, this is causing harm, and it is directly as a result of some of those decisions around licensing, for example. And I think to reassure you around the connection with the county council's role around treatment services, as Matthew said, Tony's been part of all of these conversations. So although Matthew's taken a coordinating role, which is really helpful, it's very much been a shared piece of work, and our teams are sort of very much part of those conversations. And although they will lead on the treatment side in terms of our commissioning responsibilities there, they'll also be heavily involved in any of that broader population level prevention, brief intervention, education sort of, and policy work as well.
Yeah. We've recently been doing some engagement work in Lichfield and Tamworth with peer groups that are, I mean, you're probably involved in your commissioning strategy somewhere along the line, but I mean, there's a group set up in Lichfield by ex-users who are now supporting 550 people across Tamworth and Lichfield across drugs and alcohol. And they set up 2 years ago, and they've now got 550 clients on their books. And there's a complementary organisation set up now to support families of people with addictive behaviours as well. And they're getting people from all over Staffordshire coming to their group meetings. So some of these peer-led things, you know, from the bottom up, could also help address some of these issues. And say, you know, if you thought the need in Tamworth and Lichfield was going to grow that quickly, I mean, it's incredible really how effective the services are, and they're running daily. And I think they've become mainstream now, linked in with some of the other services, addiction services in the area. So, you know, there are groups in the community who are willing to get involved as well. That's all. Yeah.
Thank you. Gary?
Thank you, Chair. There's an absolute wealth of information in this report, isn't there? I haven't begun to absorb it yet, but I guess what strikes me is something in probably a delivery plan as much as a strategy about sharing the relevant parts of this information across the ICB portfolios and other systems and different professional groups, because I suspect that there is still a lack of confidence, possibly even a taboo in other professions about talking about this as part of. So if you're talking to people with long-term conditions or disabilities or you know, a whole plethora of different demographic groups, do you also talk about the fact that essentially alcohol makes everything else worse and harder, more difficult to deal with? So I think there's a kind of a make every contact counts type approach to this, which I don't think we've exploited. And then the thing that I think is a little bit related to that, as I say, there's loads in here, so I may have missed it. I'm not sure that this addresses the cause or effect element of alcohol, and it's both, of course. It feels to me this is skewed much more towards alcohol as the cause of the problem, as opposed to the self-medication for another, even earlier problem. So I wonder if that needs just bringing out a little bit more.
So just to come back and address a few of those points, I'd certainly kind of echo the point that Richard made. There's a sense that there's an opportunity here. We're seeing shifting patterns of alcohol consumption, and Richard rightly mentions within younger generations we're seeing significantly more, significantly reduced alcohol consumption. On Gary's point, what has been notable, there is good evidence, and it's been reflected in local engagement, in that actually harmful alcohol consumption is currently quite normalised, and that is even within some kind of health and care professional groups. There's a question of how we address that, as well as arguably take a whole population approach and look to shift societal norms by looking at how through community engagement and our communications around it, how we look to perhaps adopt a stronger position on alcohol and look to denormalise alcohol consumption. So there's a lot to be done on that agenda, and I think there's certainly an appetite to look at that. The other point that Gary mentioned around looking at that cause and effects, there's a good evidence base around risk factors that arguably predispose people to having an increased life course risk of adopting harmful alcohol consumption, safeguarding, or kind of being a child in care during early years is being one group that we know are increased risk. We have had safeguarding involvement in the development of the strategy, so there's certainly been a strong focus on how in some instances we see intergenerational impacts, as in parents will have harmful alcohol consumption, the child may have exposure to kind of social services intervention during their childhood, but as a course of childhood trauma be at increased risk of adopting harmful alcohol consumption later in life. So there's, again, taking very much that whole life course approach and looking what the partnership can bring we are looking at across different partners how we can more systematically interrupt this kind of life course impact of alcohol that we see. So I think the points made are acknowledged and really value people's feedback, and I can, by means of assurance, state that they are topics that have been picked up and will look to be addressed through the strategy.
Okay, thank you. Thank you very much for that. Any further points anybody would like to raise? Okay, so one sort of final question from me before we go into the recommendations. When will you feel it appropriate to be in a position where it would be worth coming back to the board with something substantial to report on, as opposed to just for the sake of coming back?
So that's a good question to close with. We intend to have a final strategy almost supported by the Drug and Alcohol Partnership Board in October. So I think with the board support, it would be excellent to be able to bring the final strategy back to this board as an agenda item in future, if that would be supported.
Okay, perhaps we could liaise it over when the most appropriate time would be to come back and find a spot on the agenda, if colleagues are happy with that coming back. Take it that's the case. Okay, so the board is asked to note the aspirations of the Staffordshire and Stoke-on-Trent alcohol strategy, support the continuation of collaborative working for the Staffordshire and Stoke-on-Trent alcohol strategy, and support the implementation of Staffordshire and Stoke-on-Trent alcohol strategy, and promote the delivery of the strategy. So unless anyone's got any great concerns with that, I'll take that as everybody's happy with those recommendations. Matthew, thank you very much for that presentation, which we then move on to the next item on the agenda, which is the joint strategic needs assessment. Claire?
Thank you. So this and the next item I will have to keep quite brief. I'm going to try and share my screen so that I can show the dashboards. Yes, fab. Okay. So this is essentially a second or third time I think now we've been to the board to discuss this current JSNA product. So just really quick bit of context. You'll all know this by now, no doubt, but we have to produce a joint strategic needs assessment. It's one of the statutory duties of the County Council and ICB on this board. The idea is that the joint bit is around having it as a sort of partnership approach, so bringing together various bits of data and having partner input so that it's something that is a rich understanding of the health and well-being needs and outcomes of our population, and that can then be used to inform decisions around commissioning, how we target our activities, how we evaluate our services, etc. So in the past, this has typically been a static document in Staffordshire, so we were keen to try and move towards something that was more interactive and user-friendly. So as you know, we've had a steering group working on this for a few months now. We came in June, I think it was, to the board with an early draft of these live dashboards that will be automated in terms of the data being pulled through whenever there's an update in the background, but should also allow a more useful and usable interaction with the data. Over the summer, we sought feedback on those early iterations of the dashboards, and this now is a sort of final polished version of phase 1, which includes 4 life course chapters. So here in front of you, you've got the population demographics chapter. As you can see there, that's some of the main headlines of the contents within that chapter, and this is the type of data page you will see. So I won't go through each one in detail because we won't have time to do that today. But the idea is that there's a more visual and easily interpretable representation of the data so that it's clear to understand what we need to extract in terms of the key learning around the health of our population. So we have population demographics, children's health and well-being, working age population, and unhealthy ageing as well. This, as I say, is phase 1. The plan is very much to keep building on this to add layers and depth and granularity. So where we have it available, this data is at ward level, at district level. The plan is to, where we can, then drill down to ward level and to integrate more NHS data and other partner data. and anything else that we have locally that we feel is robust enough to be included. Bearing in mind we've had to be quite cautious around the sort of rigour in terms of screening data to make sure we're confident that it's accurate and robust enough to be included as part of the JSNA. And then also as part of the sort of subsequent iterations of this work, we will produce district profiles as well. So the team have already gone out to some of the districts and boroughs and attended their locality partnerships to present these dashboards and discuss what an in-depth district profile might look like for that district or borough and how that might reflect the local priorities and needs, as well as draw out any of that key health information. So it may be that they look slightly different depending on the preferences and the sort of priorities across each district and borough. So they're being built in the background, and they can also be brought back to the Health and Wellbeing Board later if that's of interest. And then the other piece of work happening in the background is specific deep dives. So there's one being developed around SEND, for example, but then also community profiles. So a lot of the work we've done across health and care at the County Council is around understanding the sort of equitable distribution of health outcomes, access to services, barriers to access, people's knowledge and understanding of services and sort of improving their own health needs. And through that, we've identified some populations or communities across our population for whom we know access might be tricky, or we know there's an inequity in outcomes, or we just don't have a huge amount of information, and therefore we know that's a gap in terms of our understanding. So the plan is to produce some specific community profiles that drill down, look at high-level quantitative data, anything that we hold that's qualitative, but also work directly with those communities so that it's more of a ground-up profile that's driven by the community themselves and is sort of owned by them as well, and produces that rich insight to enable us to understand specific groups of the population in a bit more detail. So that's where we're at now. I won't labour the point any further, but I'm happy to take any questions. The live dashboards will be available on the Public Health Observatory website, so I'll get the link sent out to everybody after this meeting so that you can access them there. And I'm happy to take any questions now or subsequently once you've had time to go and have a little play with the dashboard and interpret the data. If you do spot any snags, there'll always be improvements that we need to make. But equally, if you have any questions about the data or any suggestions for where we take it in future. Thank you.
Just to say, I'm really pleased to see this in action, Claire. It's a really good joint piece of work, I think. And for me, one of the next steps is when can we start using it in health as well, Claire? Can we start putting it on our system soon? But I think for having that joint understanding, that one version of a truth of what our localities look like will really help us targeting our resources going forward. So I'm really pleased to see it in action.
That's great. Thank you, Claire, and look forward to being able to look at that link myself, as I'm sure other members of the board do. Okay, which brings us on then to item 9 on the agenda, and again that's yourself, Claire, and that's a pharmaceutical needs assessment.
Thank you. Yeah, so again, another really quick one, hopefully. Some of you may be aware, but if not, the pharmaceutical needs assessment is a statutory requirement. And it's used to identify areas where pharmacies can contribute to health and wellbeing priorities. It informs NHS England's decisions around commissioning new activity, and approving applications or not in terms of local pharmaceutical provision. It's a statement essentially of the needs, the pharmaceutical service needs for a population, and it identifies current provision, any gaps in provision, and then that's fed back, as I say, to inform those future sort of decisions. It has to be updated every 3 years, but it is quite a lengthy process of partnership working, and so takes around 12 to 18 months to produce, hence starting now for the deadline of October 2025. So today is really just to let the board know that this piece of work's underway, and that developments and updates will be brought periodically throughout that time. I think the plan is to bring a draft report in June next year ahead of the 60-day statutory consultation period, and then for the final document to be brought in September next year for sign-off.
Lynn?
Just a very quick one. So community pharmacy has been delegated to the ICB now, although NHS England provide that central administration. Have the local primary care teams been involved, or will they be involved, Claire?
I
Yes, I'm pretty sure they have. Emma's leading the steering group, so in terms of the specific list of members, I can't recall off the top of my head. She's away teaching today, hence me presenting this on her behalf. I'll double check, but I'm pretty sure they have. Have they been included in the past?
I don't know, it's with the delegation came into effect this year, so
Yeah.
it's a new change.
Okay. I'll double check, but I'm quite confident they are.
Okay, Claire, thank you. Thank you very much for that. Doesn't look like there's any other questions or points to raise. The recommendations for this report was for us to note the contents of the report, which I'm sure we've done, and support the development of the pharmaceutical needs assessment going forward. So thank you very much for that, Claire, again. Which takes us on to item 10 on the agenda, which I mentioned previously, which is the ICB annual report, which I understand will now be at the our next meeting. Which brings me on then to item 11, which is the forward plan. And before I hand over to John, I'd just like to say that this will be, I understand, John's last meeting, where he's got responsibility for the Health and Wellbeing Board. And John's been part of this board for many years, about 10 years, I think, something like that. So, John, on behalf of the board, can I say thank you very much for all your time and efforts over the last 10 years. And while the period of time that I've been the chairman of this, thank you very much in particular for the support. And sitting to John's right is Miriam, who I understand will be from the next board taking over those responsibilities. So, welcome, Miriam, going forward. So, John, you might have a few comments to say on that, but you've got the forward plan anyway.
Thank you for that, Mark. Appreciated. Very quickly, so the ICB report is now deferred to the next meeting, and joint forward plan, if there's any update on that, probably as well. I don't know whether that will be or not, so it's there. Nikki?
Then, John.
The priority is mental health next time, so that is the item that we'll pick up in terms of the health and wellbeing objectives. Both the children's and the adult safeguarding reports are down now for this meeting because the reports should both be out, but we will double check that. There is on the terms of reference a review of the terms of reference every year, so that is also included in that. Should be a short one. Health with all policies is also on there, and now probably the alcohol strategy as well, based on what was said a little bit earlier on. So it sounds like that will be ready. At the moment, that's all that's on the agenda.
Okay, that's good. Thank you. Before we finish, any other comments, particularly on what might or might not be on the forward plan? No, in that case, thank you all very much for your attendance. As I said, the next meeting is on the 11th of December, and I hope next time we time the meeting to be exactly 2 hours instead of 2 minutes short. Thank you, everybody, for your attendance.